Thank you very much, Sabina. I'm not sure if I should thank you for signing away yet another 5 years of our lives. 10, 15, there you go. Watch it with the Lancet, you never get out. Thank you so much for your comments, which really resonate with much of what I'm going to be saying this morning. Susan Sawyer and I were last at an event like this 4 years ago in Washington, D.C., where we were launching at that time the second Lancet series on adolescent health. And at that meeting, we had a comment from somebody who I think many of you will know, Margaret Green, who's a prominent figure here, sort of working in international development in Washington, D.C. And Margaret said at that time, the case for adolescent health is overdetermined. What we now need to be doing is deciding what the next steps are and what we should be investing in. So this commission, 4 years on, is really an attempt to say what we should be doing in the adolescent health space. Now, our hosts 4 years ago were independently USAID and the Health, Nutrition and Population team at the World Bank. I'm just so delighted today that you've actually come together with the Bill and Melinda Gates Foundation to sort of be the three hosts of this meeting today. This is an area where we need sort of our major agencies and funders and donors to be coming together, so it's great to have you hosting us. So I'm going to be talking today about the findings of a 25,000-word report. I've got 40 minutes. It's still going to be a bit of a race, so there's a lot to cover. I'm going to be talking about potential and growth. I'm also going to be talking about the opportunities we currently have, together with the challenges, and what we should be doing about those challenges. So let's start with potential and growth. I figure that a few of you have actually had a child go through puberty, and you'll have some memories of what that was like. You will remember the tremendous physical growth that happened at that time. I should move my slides on just a little bit. You'll remember the tremendous physical growth. And you might have been like me, sort of had a son who was one day a little boy and the next day he was 6 inches taller than I. Humbling experience. What we've failed to realize, though, is that this is a time not just of physical growth, but it's a growth in all bodily systems. It's a time of huge neurodevelopment, a process that really continues through to the mid-20s. And yet, for a long time, we had thought that brain development stopped at the age of 7 years. That was because brains reach their maximal size at 7, but the process only is really beginning at the age of 7. What happens at about the age of 7 is you have the first hormonal changes of puberty, which triggers a whole new phase of growth and development. That's when kids are in mid-primary school. That cascade of hormonal changes, as I said, begins, girls at this time will talk about the boys beginning to smell in class. A cascade of hormonal changes continues all the way through the adolescent years and is accompanied by a cascade of changes in brains, neurodevelopment. It begins with maturation of some of those centers involved in emotional processing. It's one of the reasons why girls in particular, as they go through the pubertal years, they'll often talk about a rise and recognition of new and sometimes difficult emotions. That process of brain development continues all the way through to the mid-20s, ending with the development of maturation of the prefrontal cortex and the acquisition of higher executive functioning. It's a phase of life which is one of incredible sort of exploration, creativity. It's a time of sensitivity to the environment and sensitivity to one's place in one's world. It's a time perhaps of vulnerability also to problems related to emotion and emotional control. It's no surprise that most mental disorders begin during these years. What's not in doubt is that it brings a very different engagement of the individual with his or her social world. It's a time of looking beyond one's family of origin to the wider world. And how that engagement with the wider world, the cultural environment, the social environment, the economic and physical environment shapes, in turn, the very capacities that an individual develops during these years. It shapes identity, it shapes gender norms, values, beliefs, shapes health profoundly, and shapes, as I said, the very capabilities an adolescent takes into adulthood. So it is a time where biologically kids are primed to engage in a very different way with their social worlds. So, you might be asking, what do the social worlds of adolescence look like? Well, the first thing to say, it's a time where it's not only great heightened sensitivity, but it's a time of great diversity in the social environment. It's a time where, as Soji suggested, the cultural, economic and social environment sets the agenda in many ways for everything that's happening in the lives of an adolescent. Those shape the legislative frameworks and the policy frameworks, which in turn shape the resources available to young people. It's a time where families remain the most important immediate context for development. But this is a time of change in families. It's a time where an individual moves from a family in which you grew up to a family of your own. And that's a transition which in many parts of the globe has actually become a lot more difficult. And yet it's a transition which is critically important for health and well-being. It's also a time of transition from education to employment. Again, this is a critical transition for health and well-being, as well as everything else in a young person's life. It's a transition where, if we get it right in terms of extending secondary education, as I'll come to talk about, the opportunities are enormous. But it is a transition which is becoming difficult in many places. In North Africa, many parts of the Middle East, the expression of waithood refers to the difficulties that a whole generation is having of making this transition to a family of your own and into independent employment. Now, if it's an age of anything, it's an age of the peer group. And I want you to think about, so this is a time of life where an individual spends more time with peers, and where peers' attitudes and values and behaviours are more significant than any other point in the life course. So think for a moment about how that has changed through human evolutionary history. Think about the village, because it was the village, or maybe the neighbouring village, and the cohort of adolescents in that setting, which was the traditional peer group. Think about the modern context. As Soji hinted, the peer group today is potentially the whole world. And why? Because of media. And I want you to sort of think about how media has changed in the blink of an eye. Mass media, and in little more than a decade, the growth of social and digital media, which dominates all our lives. And I like Cassandra's comment about the internet is down. Major trauma. But it particularly dominates the lives of this generation. So this is a time of broadening of horizons. And in that, I hope I'm communicating some sense of opportunity. But the opportunity doesn't really stop there, because the opportunity that we have today is the largest generation of young people relative to other ages that we have ever had on planet Earth. We are at peak youth. You hear a lot about peak oil, you hear a lot about peak water, but we are at peak youth, 1.8 billion young people aged 10 to 24. The shades in red show where we have the highest proportion, and over a third in some of these countries of the population are 10 to 24, shown in the pink colours, and the deep blue colours are where you have this high proportion of young people in the population. And yet in places like my own country of Australia, we have a scarcity of youth. The opportunity also lies in the global strategy for women's, children's and adolescents' health. This was announced at last year's UN General Assembly. This is the first time that adolescents have been on a global international development agenda of this scale. And again, the comment from the UN Secretary General in his comment is, young people are the world's greatest untapped resource. The potential here is one of a demographic dividend which could be transformative. The risk that we face is that of a lost generation if we don't actually get our investments right. The challenge that we have as a field was captured by the editor of The Lancet, Richard Horton, in a tweet from 2012. And those of you who know Richard will be delighted with this one. Adolescents, the most pervasively neglected group in global health. It's very Richard. And he's actually capturing something which is really important. It's not to say that there aren't great needs in terms of the systems, processes, resources, technical capacity in other areas such as the health of younger children and women's health, but this area has been particularly neglected. And so that brings me to the question of what we should be doing about it. But before I get there, I just want to pause for a moment around some terminology, because the terminology in this area is a little bit confusing. So there are these terms that you're likely to come across in referring to adolescence. So adolescence is that time between 10 to 19 years in terms of UN definitions. Youth refers technically to 15 to 24. Young people is a term that technically refers to 10 to 24. And then you come across phrases like this to describe the developmental years. And this is in no way comprehensive, and it's all quite confusing, not only for those outside the field, but sometimes for those of us inside the field. But this is the age group that the Lancet Commission is primarily focused on. 10 through to 24, we're trying to capture in this the essence of pubertal development, even though it does begin a little bit before the age of 10, which marks the onset of adolescence, and those transitions through to parenthood and marriage that have traditionally marked the end of adolescence. So, recommendations. We have 6 recommendations in this commission. You'll find them toward the end of the report listed in greater detail. And they really begin with this one here, is we need to begin to think differently about adolescent health. And let me illustrate that and what we mean by that. This is where the focus of adolescent health has been, up here, where the Millennium Development Goals were focused. It's been on HIV and sexual and reproductive health in the international development space. But sexual and reproductive health and HIV relate to everything else that's happening in health and the lives of adolescents beyond health. They relate fundamentally to what's happening in terms of nutrition and undernutrition, fundamentally relate to other infectious diseases, fundamentally relate to mental health, substance abuse, even to chronic physical illness. So where does the field need to move to? It needs to move to a broader conception of adolescent health that encompasses all of these health problems that can affect adolescents. We need to go broader and deeper still. The conceptual framework for the Commission is one that extends the conceptual framework from the 2012 series, and it very much places adolescence within a life course, recognizing that what comes before is really important, and that what happens during adolescence is very significant to what happens later in the life course. Our focus within health service systems tends to have been on health problems and the response of the health service system. But as Soji very rightly pointed out, the determinants of adolescent health and well-being lie largely in sectors well beyond that of the health service system. So we need to be looking at health risks and the social determinants of health, and our responses need to encompass those community and structural and policy actions that address those determinants and risks. There's a fundamental idea here that's captured in this diagram about the need to match action to need, to health need. And an important message of the Commission is that if we get these investments right, we'll see a triple dividend from the investments. We'll see adolescents achieving their potential during the adolescent years in learning and growth. We'll see a dividend in terms of health and trajectories of health across the life course, and because this is the next generation to parent, the health and resources that this generation take into that task of parenting will be the best investment we can actually make in a healthy start to life for the next generation. So that notion of the triple dividend is an important one, we believe, in thinking about what we're doing about this field. Okay. The next slide is, for those of you who are fans of Sesame Street, is brought to you by the number 3. And that really is courtesy of Mariam Clayson, who's sitting here in the front row. And I'll explain sort of how that came to be, because when we were starting on this process of trying to design what this commission was looking like, we talked to a number of people in the policy space, and we were very keen that this wasn't an ivory tower academic exercise. So Susan Sawyer and I sort of received some words of wisdom from Mariam, which is to say what you need to do in this commission is tell us at the Bill and Melinda Gates Foundation what are the 3 things we invest in for adolescent health. Now, academics, you know, we're not very good at sort of that kind of simplicity. So we were taken aback, and this is one of these sort of elevator conversations. And I think we sort of sat down with a glass of wine to talk about how we might actually do that. But it wasn't long after that we had a similar conversation with Mickey Chopra, who's now at the World Bank. And Mickey, who at that time was head of health at UNICEF, said something similar. He said, look, it's really complicated for us in terms of planning and policies to work with a number like 192, which was the number of countries in the UN system at that time. And he said to us, look, if you could actually make some recommendations about the three groupings of countries, that'd be very helpful to us. So, in terms of this number 3, it appears many places through the Commission report, and really is that idea of matching action to need. Now, let me explain to you how we went about that in terms of defining need. And we worked with the Institute of Health Metrics and Evaluation at the University of Washington in Seattle, sort of in this work. And we worked with GBD 2013 data. And the metric that we used was the DALY, which takes into account years of life lost due to premature death and years of life lived with disability. We don't actually think that mortality is a particularly good reflection of the health problems that affect adolescents during these years, when many of the conditions that affect adolescents do cause significant disability, but they're not fatal. So what we did was to take the over 300 categories of GBD and reduce them to 3 groups of conditions. We defined diseases of poverty, which consisted of infectious and vaccine-preventable diseases, undernutrition, HIV because of its geographic distribution we took separately, and then the sexual and reproductive health problems that go with poverty and that affect largely young women. We defined a second group, which were a group of injuries. Unintentional injuries, violence, homicide dominated this group of conditions. And then we defined a third group of non-communicable diseases affecting adolescents: mental disorders, substance use disorders, and chronic physical illness. This reflects something of the direction of the epidemiological transition which happens with economic development, changing patterns of fertility and mortality that countries move through. And on this basis, we defined 3 groups of countries. We defined a group of countries where adolescents are affected by that triple burden, the multi-burden countries. They're affected by all of these conditions. And that group was defined by a daily count of over 2,500 per 100,000 per annum for these diseases of poverty. We defined a similar threshold in terms of injury excess countries, where it was these problems of unintentional injury, violence, homicide that dominated the picture. And you may already be thinking, whereabouts are these countries? I'll show you in a tick. And then the remaining countries where the predominant problems of adolescents are NCDs. So where are these countries and what do they look like? Well, this is the map. Apologies, those colours aren't as good as they should be. But the purple colour reflects those countries that are the multi-burden countries. So in sub-Saharan Africa, South Asia to a very large extent. The injury excess countries are shown in the orangey colour, and so these are countries of Latin America, Eastern Europe, Central Asia. And then the green colour reflects those countries which are NCD predominant. 51% of the world's population of adolescents are growing up in multi-burden countries. 51%, and they account for almost 2/3 of the disease burden affecting adolescents in the world today. Let me show you what's happening over time with that disease burden. And let me start with NCD predominant countries and looking at trends in health in these countries from between 1990 and 2013. So 1990 is shown over here on the left, and 2013 on the right. This is females and males. What you can see here is that in NCD-predominant countries, there's been an improvement over this time, but most of that improvement has been around reducing unintentional injury, particularly in males. Looking at injury excess countries, you can see here the excess burden of disease in these countries is largely affecting males, and it is the problems of unintentional injury and, in many places, homicide and violence as well. And then if we look at NCD-predominant countries, the multi-burden countries, we see that here there has been some improvement. The injury excess countries look a little bit stuck in terms of trajectories of burden of disease. For these countries, there has been improvement. The improvements have actually been more in young women than they have been in young men, and they have been around the problems of infectious disease and reproductive health, so there have been gains. The burden of disease is now somewhat similar to males and females in these countries, but the burden of diseases of poverty is still greater in young women than young men. What you see in these countries is the sort of this ongoing burden of unintentional injury and, to a lesser extent, homicide. And what's clear in all of these countries are these NCDs. They're not shifting in any country, whether we're talking about the United States and other sort of higher income countries, or whether we're talking about our multi-burden countries. Now, in the Commission report, we're going well beyond disease burden in terms of profiling health. And let me give you a couple of examples. First is what's happening around the health risk of obesity in this age group. This shows the current prevalence. This is actually, this bit shows the current prevalence in 2013, with the red colours showing prevalence of over 40% in countries of overweight and obesity. The blue colours are under 10%. There's not much blue on that map. Looking across our country categories, you can see that this trend toward high rates of obesity is already affecting our injury excess countries and beginning to affect adolescents in multi-burden countries. If we look at change, the pattern is stunning. Those deep red colours reflect an annual change since 1990 and 2013 of over 5% per annum. That is an astonishing rate of change that we're actually seeing in many countries. The grey countries are the ones where there hasn't been significant change in overweight and obesity since 1990, and there's very little grey on this map. And what you can see over here on the right is that that rate of change, particularly in young women, in multi-burden countries, is also accelerating at a similar rate to what we're seeing in injury excess and non-NCD predominant countries. And that becomes an issue not just of NCD risk in the future, it becomes a risk in terms of maternal health and the health of offspring as well. Looking at a very different picture, one that's somewhat moving in the right direction, is adolescent birth rates. Here are the rates, current rates of adolescent births, with the deep red representing rates of over 100 per 1,000 girls per annum, whereas the deep blue represent rates of under 25. So there's still a huge variation across the planet in terms of adolescent birth rates. But if we look at rates of change, they're actually moving. The blue is good, the red is actually increasing rates. And for most of the world, we're actually seeing a favourable change in terms of adolescent birth rates, and that's a good news story. If we look across our categories in terms of current prevalence rates, the highest rates currently are in our multi-burden countries. But if we actually look at the rates of change, those are also the countries where we've made the greatest progress. And where we're making less progress are actually, interestingly, this group of countries that are the injury excess countries, Central Asia, Latin America. And if those trends were to continue, the highest adolescent birth rates in coming decades may well be in those countries. Okay, I want to move us on from patterns of need to what we should be doing about adolescent health. And the first thing I want to talk about is universal health coverage. Soji has already mentioned this. And if there's an age group in terms of achieving universal health coverage that is more important than any other, we believe it's the adolescent age group, who have their needs least well met of any age group currently across the population span. We explore in the Commission the reasons for this. And to illustrate that, I want to put up the UHC cube that many of you will be familiar with. So we explore some of the reasons within the system, why adolescents are poorly served. One of the reasons is that adolescent healthcare practitioners, or healthcare practitioners, find adolescents more difficult to deal with than any other age group. They feel less well trained to deal with adolescents, and this is a consistent story. We know that in many parts of the world it is the judgmental, the stigmatizing attitudes, the inability to maintain confidentiality that is a real barrier to adolescents seeking care around, particularly around health problems that are sensitive for them, around things like mental health and sexual and reproductive health. It is the reason why unmet need for contraception in sexually active unmarried girls is twice as high as it is in married girls. We explore some of the reasons beyond what is currently provided as well, why adolescents don't have their needs well met. We look at the financing envelope. Who is covered? Adolescents rarely are formally part of tax-funded or insurance-funded health care. They're dependent on their families. If their families don't have cover, adolescents don't have cover. If adolescents are living outside of their families, they don't have cover. The kinds of things that are covered by services aren't necessarily the major problems affecting adolescents. We've tended to do better around things such as sexual and reproductive health and HIV, but not other infectious diseases, not mental disorders, not chronic physical illness in terms of what is covered. Adolescents are the poorest members of most communities. They have the fewest financial resources, so they're the most sensitive to out-of-pocket costs. And if you actually have a catastrophic event affecting an adolescent or perhaps an adolescent's family, particularly for girls, this can be a devastating event in terms of future life chances. And we explore beyond the envelope of what we're thinking about in terms of current health service systems for adolescents. Currently structured adolescent health services don't necessarily work well for adolescents, and they don't necessarily take into account the developmental point that adolescents are at, how they're living their lives. And so we believe that there is a need to consider other strategies. We need to consider much more school-based healthcare delivery. We need to consider community-based strategies, mobile strategies. We need to consider the electronic and digital delivery of health services, either to improve access to traditional services or to deliver healthcare interventions. Now, the intersectoral bit is really important in adolescent health, and Soji's already flagged this. Some of the best interventions we can make in adolescent health are actually going to be in sectors beyond health, and we believe that one of the best investments of all is keeping kids in school and keeping adolescents in school. So Russell Viner and the team from University College London with Chris Barnell sort of undertook a series of analyses of the association between sort of education and a range of health outcomes, extending to mortality and maternal mortality. This one here is an illustration of the relationship at country level, so it's an ecologic analysis, but demonstrates the association between years in primary school and reductions in teenage birth rates. Extending secondary education for girls into lower secondary results is associated with a reduction of 48 fewer births per annum per 1,000 girls. That's a huge reduction. Extending to the end of secondary education is 68 fewer births annually per 1,000 girls, aged 15 to 19. These are huge reductions. The associations we find, that Russell and his team found, when looking at individual studies, cohort studies, were very much the same. The message is the interface between education and health is a really important one for this age group, and extending secondary education is a really good investment. Terry McGovern and her team at Columbia University did a second piece of work looking at the legislative frameworks around the health and well-being designed to empower young people around their health and well-being, or in many circumstances do the opposite. So Terry looked at 6 case studies, India, Lebanon, Nigeria, Peru, Sweden, and the United States, to ascertain how consistent the legal frameworks were across these different settings. What do you think? Do you think they're likely to be consistent across countries? Absolutely not. If you take something like the age of criminal responsibility, it varies from 6 to 18 years across countries and across offence. Take the minimum age for marriage, it varies from 9 through to 21 years across country. And you might say, well, it actually becomes more consistent, surely, as countries reach a higher level of economic development, but the comparison of Sweden and the United States really illustrated the huge differences between two higher income countries. And even within the United States, there are massive differences within states. And you'll see here these countries of India, Lebanon, and Nigeria, where the shading is in yellow around legislation. And these are settings where customary or religious law supersedes national legislation that might be good national legislation, but effectively customary law is the dominant law form, so that even if you have good legislation around a minimum age of marriage, what is customary actually sort of takes precedence. Terry is here, I think, today. I think, Terry, are you here? Terry, you're here. She'd be very happy to talk further. It was a fabulous analysis that she's done. The theme of engaging and empowering young people is a theme that we took very seriously on the Commission. We had two young commissioners, Kikalama Taiwo, who's here today, and Dakshita Wickramaratne. I still struggle with Dakshita's name. But they were fabulous contributors to the piece of work here that was, they worked with Suzanne Petroni from ICRW here in Washington, D.C., around this piece of work, examining the current evidence base for youth engagement and the models that actually work. Probably Kikalama is, I think, going to talk more about this, so I'm not going to say too much, except to say that if anything is overdetermined about adolescent health, it's the need for youth engagement and empowerment. Young people have the capacity to transform our thinking in creative ways that we're not utilizing, so we are not walking the talk. We, in our conceptual framework, sort of look at some of the underpinnings of youth engagement and empowerment and the need to sort of give young people the resources to do so. So Kikalama is going to be talking in a tick. Kikalama didn't just wake up one day and decide, I have everything I need to be a youth health advocate. It's actually the result of years of experience and training and mentorship. And we're not doing this in any systematic way. So currently, we believe there's a need for training of young people around the skills necessary for being effective advocates. We need to systematically put in place the partnerships and the mentorship for young people to ensure they do this task well. We need to ensure the systems and processes are in place so that it's not just token engagement, but real and meaningful engagement with processes and decision-makings that shape their lives. And young people need to be resourced to do this. So Kikalama today has got a fabulous employer, who has allowed her to actually come here today, but she's not being paid for actually doing this task that she's doing today, unlike the rest of us. We believe if we get this right, the dividends will be huge in terms of improved healthcare systems, not just for young people, but beyond young people, as well as it's good for young people to be engaged in these kinds of processes. Ultimately, it's better health capital and better human capital that we are creating in this process. So the last recommendation is really about knowledge gaps. And in some ways, this could be the most challenging and the most important of the recommendations. In the Commission report, we very much look at knowledge gaps within the framework of accountability. And I'm going to do so here in terms of talking about them. So, first step in the accountability is taking the account. And it's fair to say that we have some real challenges in this field about how we take the account. We have a tremendous problem with our primary data. Our current systems are haphazard, poorly coordinated, little harmonization. So we have huge gaps around our knowledge of health problems at a global level, at a national level, at subnational levels. Our focus has tended to be on sexual and reproductive health and HIV. Other areas, including other infectious diseases, our knowledge is thin. Problems such as substance abuse and mental disorder, almost non-existent in many places. We have a real challenge here. We have groups such as younger adolescents, adolescents who are out of school, and we're not capturing any data at all on. So there is a big challenge here, and we're going to need to harmonize our data systems better. We're going to need new data resources. But we do believe that there is an opportunity to use some of our existing data better than we are currently. So in the Commission report, we give the example of Nigeria. We had 2 Nigerian commissioners who we consulted with about this. Do not try and read this. Do not try and read this. It's really to illustrate that it's there in the report. Look at the report. To say that we can actually now put together a fairly good estimate of the burden of disease and the things that are affecting adolescents in any country. We can talk about the health risks affecting adolescents in any country. We can talk quite a lot about the social determinants and the service platforms that exist within any given country. And on that basis, we can come to some fairly broad but valid recommendations about what the priority health problems are for adolescents in any country. But we're not currently doing this. We can even sort of look at subnational profiles. So we looked at the subnational profile of China. China, on the whole, Chinese adolescents are actually doing pretty well in terms of their adolescent health. But we had a Chinese commissioner who said, oh, no, it's very different in different parts of China, and she was right. In the eastern provinces, the problems of adolescents are largely NCD predominant. The western provinces, the problems are actually a mixture, and they're better classified as injury excess, not NCD predominant. And that's true of every country. Our accountability process went on, from talking about taking the account to sharing the account. And again, this is sharing the account and sharing data, not just with government departments, but sharing it with civil society, sharing it with young people and young people's advocates and young people's organizations. We're not currently doing this. It's about the need to create forums where civil society and young people can discuss with government the investments that governments are making in adolescent health. We currently don't have those forums. And it's then about responding to the account. Now, part of the story, as Sochi, I think, eloquently said, part of the story is matching action to need. And needs vary hugely, and responses vary hugely within countries, between districts, between states, and between countries as well. And it's also about using the best evidence-based practice. So you will find the most comprehensive meta-review we think has ever been done of what works in adolescent health within the Commission report. That was was led by Nikki Reevely, who's based with us at the University of Melbourne. It was a huge undertaking. And I've put together what is a qualitative evidence gap analysis of what we know and what we don't know. So this is my interpretation of this meta-review that really covered all of those 9 areas that I described earlier and related health risks, and just picked out a few in terms of what we know. And what we know well, or reasonably well, is shown in green, the deep green. The paler green here represents those interventions and actions from platforms. So these are 6 different platforms across the top and the health problems along the side here. The paler greens represents those areas where we have some promising actions, where the reviews are either mixed in terms of the evidence base or the evidence only comes from high-income countries and mostly from the United States. The other greys represent those areas where we just don't have the evidence. The paler grey where we have perhaps some studies, the deeper greys where we have no studies. And what I want you to see is that there's a lot of grey on this palette. Now, you might say, well, it's looking pretty good for sexual and reproductive health and HIV, and you're right. That's where the best evidence lies. And I think there's little doubt that conditional cash transfers work to produce good sexual and reproductive health outcomes. Evidence around comprehensive sexuality education is pretty good. And increasingly, the evidence about youth-responsive, youth-friendly sexual and reproductive health care is actually pretty good. But even if you look within sexual and reproductive health, there are huge gaps in our evidence base. We were surprised, for example, there are almost no studies looking at families in relation to sexual and reproductive health. Why not? Families are the most important entity. 1 minute. I think I'll be pretty good. Okay. Are really important in the lives of young people, but we're not looking at them in terms of the intervention base. We don't have cost-effective analysis in many low and middle-income countries around something we know is important and works, comprehensive sexuality education. Looking at these other areas of importance, we've got a largely grey palette around sexual violence, where the evidence that we do have around community interventions comes from largely high-income countries, around obesity. Again, the evidence is thin and looks best around policy policy interventions, taxation in particular. We have really promising areas and platforms such as E and M health platforms that we're just not looking at. And where we are looking at them, we're only looking at them in high-income countries. So there's a huge agenda of work here. Lastly, we looked at the drivers of the accountability process. We placed young people centrally in this, and Kikolan will say something more about that. And we also talked about the importance of independent oversight. Adolescent health. It's been an area which has been everywhere and nowhere. At a global level, it's everywhere, but there's no clear point of accountability. And again, at national level, it's the same kind of thing. So we flagged some suggestions there about national youth commissions as a possible mechanism. I'm going to finish now. I just want to acknowledge my colleagues, the commissioners. I want to acknowledge the lead institutions, Columbia University, London School of Hygiene and Tropical Medicine, University College London, and the University of Melbourne, who formed the partnership that underpinned this. I want to acknowledge our funders, the MacArthur Foundation, and in particular the Bill and Melinda Gates Foundation, without whom this work wouldn't have been possible. And I'll leave you with the words from the front cover. This generation of adolescents and young adults can transform all our futures. There is no greater priority in global health than ensuring they have the resources to do so. And with that, I'm going to pass you over to Kikalomo Taiwo, who was one of our 2 youth commissioners, who's going to be talking more, I believe, about the youth engagement and empowerment strategy. Kikalomo was, at the time, based in Nigeria, but she now lives in New Jersey, and so it's been a shorter trip for her today.